and I was at my keyboard, I was at work, and my hands just stopped moving one day and I just froze. I couldn't function. And I went home and I spent some time resting, got a bit better, went back to work and immediately crashed again, and then had to have about 18 months off work. So that was a real shock. I've talked to colleagues since then and nobody really saw it coming. I definitely didn't see it coming. I was just in my very busy parenting, teaching, doctoring world, and the wheels kind of came off.
Welcome to Flourishing in Medicine, from Surviving to Thriving. I'm your host, Dr. Mick Krasner, and this podcast is produced by MPro, a professional medical liability insurance carrier in New York State. And it's committed through this podcast and other offerings to support physicians. In this episode of Flourishing in Medicine, from Surviving to Thriving, I'm joined by two colleagues, Doctors Susy Stirling and Sandy Miles from the United Kingdom. These physicians' paths through medicine, education, personal discovery illuminate what it means to truly flourish as healthcare professionals. Dr. Stirling shares how her early exposure to inequality and justice, shaped by family history and years of practicing in rural South Africa, led her to public health, coaching, and creating spaces where health professionals can reconnect with their values and purpose. Dr. Sandy Miles describes how her mother's illness and her own journey through burnout, identity exploration, and a transformative medical humanities program deepened her understanding of what it means to be a whole person in medicine. Together, they reflect on the critical role of storytelling, connection, and emotional intelligence in healthcare. They describe their collaboration on the National Health Stories Experience, a powerful platform that invites clinicians to share personal narratives that speak to hope and humanity. Drawing from experiences as educators and coaches, they explore how shame, when named and understood, can point toward core values and foster growth. The conversation ends with a shared vision for a future in healthcare, where listening is prioritized over speaking. Emotional awareness is cultivated from the start of medical training, and professional identity is rooted in authenticity and compassion. Please enjoy this wonderful three-way conversation with Drs. Susy Stirling and Sandy Miles. Welcome, Dr. Sandy Miles and Dr. Susy Stirling, to Flourishing in Medicine, from Surviving to Thriving. It's really great to have you here.
Thank you. It's lovely to see you.
Thanks, Mick. It's a pleasure to be here.
Great to see you again. We met a month or two ago in the UK, where you reside, in Exeter, at a wonderful Shame in Medicine conference. I wanted to remind you this podcast is about flourishing, our health professionals flourishing. And I was interested in having a three-way conversation specifically with the two of you because of how your histories and interests and experiences, in a lot of ways, maybe you don't see it this way, but address flourishing both individually as a health professional, physician, whatever, and collectively for health professionals. Many of our podcast audience are physicians and other health professionals and other folks. So I wanted to start with kind of a little background question. We can say, why medicine? And I want to see if you can go beyond biography. What I mean by that, not the chronological, step-by-step, instrumental progression of your medical career and choices, but what was underneath that as a person, whether it's from your childhood, your upbringing, your milieu, your experiences. And I'd really love to hear from each of you. Why medicine? We could call it the origin story. So, Susy, why don't we start with you?
Well, I think I would say, for me, there's an origin story for medicine itself, and then there's also an origin story for public health training, and then there's a different origin story for coaching, and I do a lot of coaching now. So that's three strands that come together. But the medical one, it's Sandy that lives in Exeter. So I live in Sheffield, and I grew up in Edinburgh in Scotland with a grandfather who had been a refugee from Nazi Germany and then received his medical training in Edinburgh. And so a lot of my childhood stories about health and healthcare were influenced by his experience. And because of his gift of education by Edinburgh University, he had decided to give his career to a pretty rough part of town. So he was a general practitioner in an area of deprivation. And I remember the stories about people, this is immediately prior to the inception of the NHS, people paying for their medical care with cabbages from their garden. So poor people unable to afford healthcare and having to make really tough decisions about food or purchasing wellness. And I suppose it made me think about health as a human right and health as a commodity and who gets to be healthy. And that was really interesting to me. So at school, I was a kid who was okay at science. So I was more interested than people than things. So I was going to go down the medical route rather than the engineering route. And that's broadly why I chose medicine. But actually already I can see now looking back that there was some stuff going on there for me around inequalities, around vulnerable groups, around equity and justice, and some principles, I think, that have fascinated me ever since.
Before we move to Sandy, you really tickled my interest a little bit in kind of, even if we could drop just one step further, the inequalities, the inequities, and the healthcare systems, and people, barely being able to figure out how they're going to obtain healthcare using cabbages to pay for it. Do you understand why that affected you? What was it about you as a person that, for some people that could just be, oh, that's an interesting part of life, and accepting that and not really more deeply feeling that. Why did that have an impact on you?
Well, I think it was the circular nature of it coming from a grandfather who also, he didn't talk about it because he just didn't share this sort of stuff, but my mum talked about it, about the discrimination that he received. So it was really hard to be German around the time, immediately after the war in the UK, for obvious reasons. And so, he was spat out in the street. And I think it was something to do with justice and fairness that had already been sort of laid in those stories that didn't seem okay. And the fact that he had made an active choice to give back to that community, it was really striking to me. So there was something maybe beginning to kind of brew about one's own agency, or what choices one makes that can have an effect. To be honest, Mick, it's a fascinating question, and I'm not sure that I've done the due diligence. I think you could probably talk to this for some time. But I guess those are first thoughts that pop up in my mind.
So Sandy, for you, why medicine? Out of all the things you could do with your life, why was this the one that you chose?
I guess, like her, my first thoughts have come back to my family. There is nobody that I'm aware of in my family who is a doctor or was a doctor. Well, so there are now currently doctors, but they weren't in the generations previous to me. And I think the most important person in my life as a young person was my mum. And she was a science teacher. And I don't know at what age I discovered, I think probably by accident, she probably just said, well, I really did want to be a doctor, but my parents wouldn't let me because the training was going to be too long and they couldn't afford that. And I guess that thought probably lodged in me at some point. But she also was somebody who was very ill and disabled throughout her life, with very severe arthritis, and ended up dying at quite a young age from it. So I think I had contact with the medical world from a very young age through her experience, not my own, but through her experience, and recognized the kind of, I guess, the highs and the lows of that medical care, which was sometimes exceptionally good and sometimes exceptionally poor. And like Susy, I was kind of good at science, and obviously I had that real science bent at school. Although when I reflect, actually, I was equally interested in in English. And I remember having a heated argument with my school to be able to do the English A level, which is like a kind of our school leaving exam, and was refused because I couldn't do both. And I felt that was very unjust. So I've kind of held on to that link, I think, but that didn't exist anywhere in my family. Nobody else was interested in English. So there was no environment where that would have been supported or promoted, I don't think. So I think I say you, I shouldn't generalize, but I think we are all hugely influenced by the environment in which we grow up in. And although there were no doctors around, I think I just naturally followed that course. And in my mind, I think a doctor was probably quite a heroic character. That was probably part of the attraction as a young person. It felt quite a heroic thing because I didn't know any doctors, so I didn't know about the challenges of medicine. It just looked like it you did in a kid's storybook. It was a kind of a heroic person, right? So I was probably hopelessly naive about the reality of what a medical career looked like. I had no idea really. And I think I contrast that with one of my children who's now a doctor, who's watched me all the way through her life. She's very aware of the ups and downs of a medical career. So my experience has been so totally different to hers.
Can you walk us now through, after that decision and that unfolded in the way that it did, the events, decisions, experiences that led you to your current work in what I would call the category of flourishing? And you'll describe it, I'm sure, in the nuanced and more personal way. And each of you will ask this too. But Sandy, why don't you walk us through? You get your medical training, and then what happened?
Yeah, well, I guess like many doctors that I've met and taught and worked with over the years, it's quite a windy road. It was certainly not the straight path that I think people had envisaged, or I had envisaged, I guess. So I did my medical training, and then I did my first 2 or 2.5 years as a young doctor. And when I was quite undecided about but I started to realize I really didn't like hospital environments. So I'm very aware now as a much more mature person that environment is really important to me, and I appreciate it's not actually for everybody, but it is to me. And I really didn't like the kind of windowless hospital environment. I really didn't like people in pajamas. And that's not the staff, because at that time we weren't wearing pajamas. People do now, but the patients were all in pajamas. And I really found it very dehumanizing. I didn't like talking to people when they were in that vulnerable state. That really registered with me while at medical school, and it kind of became worse and worse while I was a very young doctor. So, but then we went and lived abroad for a while. We went to France and we went to Germany with my husband's work, and I had 3 children in that time. And so I was actually 5 years out of medicine, and I had this extraordinary experience. I came back and thought, wow, gosh, will I ever be able to do this again? I kind of had a real loss of confidence. And I also thought I'd really like to try not being in a hospital. I'd had no real student experience as a general practitioner. I think we had about 2 weeks in our entire medical training in a GP practice. So it was a bit of a shot in the dark. And I just approached the head of training and said, could I just try it? Could I try general practice? And they were like, yeah, sure, go and have a 6-month post. So I was very lucky in that I didn't really have to commit. I could just try it out. And that's something I know is not always available to people now, but it was then. And I can remember very clearly going into that GP surgery, which was very close to my home at the time, and feeling instantly comfortable, instantly at ease, addressing patients in their normal clothes, sitting in an equal chair, being able to talk about this and that, and addressing their health issues. And it was a very instant connection and link for me. So I felt very comfortable there. I've completed my GP training, which involved me having to go back into hospital, which was quite challenging because it really highlighted the institutional nature of hospitals, which was not my space. But I kind of gritted my teeth and got through that part. And I really fell in love with the ethos of general practice training, which was very, very focused in this area around communication, around advocating for patients, around supporting their shared agreement in terms of planning, investigations and management and so on. So it all kind of came together, and I found myself probably my most comfortable space career-wise was in the GP education realm. So I found like-minded souls. I found it exhilarating to be facilitating our younger doctors to learn. And that was really where I kind of really what I would call flourished, was in that space. And I then experienced an episode of what probably is termed burnout, really. And I was at my keyboard, I was at work, and my hands just stopped moving one day and I just froze. I couldn't function. And I went home and I spent some time resting, got a bit better, went back to work and immediately crashed again, and then had to have about 18 months off work. So that was a real shock. I've talked to colleagues since then and nobody really saw it coming. I definitely didn't see it coming. I was just in my very busy parenting, teaching, doctoring world, and the wheels kind of came off. And that was a huge learning experience for me, very humbling, very shaming, as I've kind of come to maybe later, to be a doctor who became ill, particularly with what people would label as medically unexplained symptoms, which is kind of the awful term that we have for these symptoms. And it took me a long time to kind of clamber back onto the horse, as it were, and get back into my clinical practice and my teaching practice. So it's been windy. I've worked actually in lots of different practices, which I'm very grateful for. I think I've had extraordinary opportunities. I've only ever really had a proper interview for one or two of the jobs that I've done. Most of the work I've done, I've contacted somebody and said, I'm really interested in what you do. Could I come and talk about it? And a kind of a role follows from there. And that's my, I guess that's how I work. That's how I've been comfortable and how I've found spaces in which I can flourish. And I'm very aware that's kind of particular to me and that wouldn't necessarily suit everybody, but it's been my way of making sure that I find spaces that actually work for me. And I no longer worry about whether they would work for everybody. I kind of want to make sure that first and foremost that they can work for me, and then I can help other people flourish in those environments, because we all do have quite particular needs.
Yeah, I'm thinking about your description of climbing back on, as we use the metaphor, getting back in the saddle, so to speak. One of the questions I have right now is, were you really just going right back to it just like you did before, or did something fundamentally change? And maybe you can just think about that in how you saw your identity and your role and how you approached your work after that period of burnout and that break. I suspect, there may be some resonance with that, but I want to turn to Susy if I could. So the events, decisions, experiences that led you to the work you do now, which, like I say, and Sandy came really nicely around to it, helping others flourish and yourself flourish.
Yeah, well, like Sandy, it's windy, it's non-linear. So I did my first few jobs in Sheffield, which is where I graduated, and enjoyed them, but felt really lost. I didn't actually know. I was so jealous of those people at medical school that knew exactly what they wanted to do. That was never my experience. I had, however, had two electives abroad. I had one in Zimbabwe and one in Ghana, and I really, really enjoyed those. And so I applied in the back of the BMJ, there was tiny little adverts, and one of them was for a medical officer in a rural hospital in South Africa, and I applied for the job. And went out there for a year and loved it and stayed for 2. So this was rural KwaZulu-Natal, very impoverished farming communities, really forced to be on that land and not on more kind of abundant, productive land, and living in poverty. And what was really interesting about the medical work was it was so collaborative. So we were a small group of 10 doctors. We had 200,000 patients in our catchment area. We all did surgery, anaesthetics, obstetrics, quite a bit of trauma. I can still remember somebody having his hand chopped off in a fight over a chicken. Often we had caesarean sections because the hospital was situated right next to a beautiful, beautiful game park, which had a lovely tarmac road winding through it for us to go and have a look at animals should we wish it on our days off. And the road to the hospital, which was alongside that, was really potholed and challenging to get through. So we knew that if a patient had made it in labour, advanced stages of labour, because they wouldn't come until they really, really, really needed the hospital, sometimes in wheelbarrows, if they made it up the road, they definitely needed a section. Like there was no way a woman in labour wouldn't have given birth on that rocky road. And, those were the kind of everyday oddities. Like another oddity was the fact that we saw quite a lot of snake bites, children with snake bites. We didn't have shoes, so they would come in with a snake bite certain seasons. And we could, as hospital staff, liaise with Devon and get a helicopter to evacuate that child to ICU. And yet that was a child without shoes who probably didn't have enough to eat. So there's just this real kind of front and centre view of inequality. And South Africa is an extraordinary country. I mean, it's so beautiful and so incredible in so many ways. But blimey, it's got a hill to climb in terms of tackling inequalities for obvious reasons, historic reasons that are so deeply entrenched and so challenging. But it was really shocking to me to what extent the inequalities affected people's health. So the other big thing that was going on in the time was the rise of HIV. If you can imagine a rural community that doesn't have enough money to live on or enough resources because the farming land is so poor, what do? Of course, they migrate for labour. So they migrate to the cities and they're at the mercy of people who want to make as much profit as possible. So they say you can only visit home once a year and you have to live in these multi-person hostels, and no, you can't have healthcare. And so, of course, all the tinder was there for this to explode in a giant fire. We had people who obviously had new relationships in the city where they worked, but without primary health care and burgeoning sexual infections, and then throw HIV into that mix. And, as we know, it's much more likely that you'll contract it if you've got concurrent infection, and people do. So they then came home to the rural area and brought the infection with them for their visits. And the striking thing about HIV and what was different at that time was it was a whole community illness. So parallel to that in the UK, I think it was the men having sex with men community and the gay male community who were really feeling the hurt then. But in our community, it was anyone in a sexual relationship was at risk. So, we lost the hospital social worker, we lost the hospital matron, we lost the hospital lab staff, we lost lots and lots of nurses. So it decimated the caring population. And it was a really striking example of what needs to happen outside a hospital for that to be a health service. It was really a sickness service. So what does it take? I mean, I suppose these are the questions that I was asking myself. What does it take for something to be a health service and not just attending to sick people? What's the preventative work that we need to do first? Not just for staff in terms of infectious diseases such as HIV, but how about, children eating well or being vaccinated and immunized or having access to clean water and education and opportunity and they're flourishing, the chances for them to flourish. So all of those components came together. And I think by the end of that time, I'd already extended for another year. So I was there for 2 years. I came back and did a master's in maternal and child health because I'd done quite a lot of child health while I was there and thought about going back to do that. But during that year, various things changed personally for me, and I really wanted to be back in the UK rather than living there. But the interesting thing, I now see it's interesting. At the time, I couldn't make head or tail of it, but I did my dissertation on the hospital staff and the choices they make to work rurally, because my own experience had been it was such an enriching place to work. It was just fantastic. The teamwork was incredible. The support was incredible. The learning opportunities were incredible. And it was really supportive. So it's a wonderful place to be. Pretty scary at times clinically, but you didn't do things unless you were confident, and you got confident by other people helping you and teaching you. And so that dissertation was really exploring what there's this incredible untapped resource. Why isn't this seen as more of a kind of asset to the country? At that point, there was a dialogue going on nationally about compulsory rural medical attachments, and people weren't having it. They just did not want that. So it was an exploratory piece of work, and it was a qualitative piece of work. So now I'm beginning to see threads appearing of words, stories, people understanding themselves, but also staff well-being. How do we look after people? How do people flourish? How do people find what's right for them? And when I came back, as I said, did the master's thinking I might do paediatrics, but it's pretty obvious to me after doing a clinical job in it that wasn't going to work for me. And so I jumped into public health training, and I really loved public health training. This is in the UK. Really loved it. It's fantastically diverse, really rich learning. You start with a master's in public health and then move on from there into lots of different placements. So it's wonderful in lots of ways. But the other thing that was happening to me at that point was I was starting a family, growing a family. So I had 3 maternity leaves, and each of those was fine, apart from a bit of hyperemesis, they were fine. But when I came back, would you believe it? I timed it perfectly. For at the end of each of the 3 maternity leaves, I came back to massive NHS reorganisation. So unknown organisations, unknown structures, unknown accountability, unknown budgets, really difficult to get things done. Organisational memory has left, morale has depleted, all the things we know to be true about change were writ large. And I could not believe that it happened 3 times. I mean, we now know this is a repeat phenomenon. We're going through it right now in the NHS again. It's so tiring and boring, and it doesn't appear to achieve the aims it sets out. But what that ignited in me was a wish to understand change better and to think, really, is this the best that we can do for our staff? They're so well trained and resourced. They come to work wanting to do a good job, and then you take away the tools. You take away collaboration, you take away people, you take away memory, you take away resource. And not surprisingly, people get fed up. And so I began to explore organizational development. I trained as a coach. I saw that coaching could be really useful in medical education. And by that stage, I had an education role as training program director, which is a name that we give to somebody that works out how we're going to train the public health registrars. So I was doing that kind of educational arm, really enjoying it, but spotted that actually we could be doing more for people because they were at that early stage in their career trying to combine quite a hard sort of regimen of exams and milestones with life, with, babies or no babies or illness or sick parents or caring responsibilities or whatever. And actually coaching is really excellent for that, giving people space and time to think for themselves. And what medical education, I think, sometimes denudes people of is the ability to think for themselves. In other words, we furnish them with wonderful algorithms and evidence base and guidelines and pathways, and we tell people the most economical, best way to do things, but we don't say to them, what are your genius ideas? And obviously we need both, but I think we run the risk of allowing people to stop using that independent thinking. So that was the particular style of coaching that I became interested in. It's Nancy Klein's Time to Think coaching. And I set up a coaching scheme in the deanery, which is the postgraduate medical education system that I was working in, because it felt like something that we could do with. And it was just interesting to me as well that in other parallel professional spheres where there was a lot of responsibility, coaching was an obvious added value professional tool, and yet we didn't currently have it. And I've seen over the years coaching as a way to help people flourish. So that was the kind of start of me beginning to explore things that help people flourish at work. So I did Myers-Briggs training, and I trained to run action learning sets, and I did some other psychometric training, trained as a 360 appraiser, and this kind of suite of things that basically is about listening to people and helping them identify what's going on for them and think through critically. Can I keep going? Do I want to keep going? Is this right for me? What would make it better? How could I make it, more easeful or more flourishing environment? So in parallel to that, I guess I was flourishing because I was finding the things that I was most interested in, which certainly I had no idea of. I mean, that is not the conversation that one has with a careers teacher at school or even medical school. But these were just found along the way as kind of jewels along the path, if you like. And that takes me to now, where I run a coaching scheme and supervise coaches and run a leadership fellowship scheme. And then I also do quite a lot of delivery of leadership training around things like imposter syndrome and complexity in leadership and things like that. I can talk more about that if that's interesting to you.
One of the things you spoke about this time to think that this coaching training helped you with, but also as I was thinking, one about a take home of this conversation is making a space for us as professionals to take that time. For you, maybe it was those maternity leaves, but your time is filled up with having the children and doing all that. But I think many of us in the continuum of healthcare training find that we don't stop long enough, figuratively or literally, to actually think about where it is that we're going. And I think it's maybe magnified in the US, but maybe not, where students are making decisions about their training trajectory that will carry on for decades with very little time to really investigate and explore what that means. So, thank you for that. It's really, really helpful. I think our listeners will find that helpful. We're going to come back to another aspect of your work together, the two of you. But before we do that, I wanted to turn back to Sandy, and I wanted to hear a little bit about the medical humanities training. I'm thinking about your A-levels in English literature, and I'm thinking about, what happened in that program to you personally and professionally, and did it have anything to do with this period? Maybe it didn't, that you spent away from medicine, sort of recovering and taking care of yourself. And, you write and you think about professional identity, and hopefully we'll get to some of that. I wonder if you can speak to just that experience, getting a master's in medical humanities, in that program's effect on your own professional identity.
That was a really windy path to get to arrive at that space. So I think your question to me earlier was, how did I change after that burnout? And I've kind of been reflecting on that and thinking, well, what did change? And I think primarily the thing that changed was I quietened down my inner critic. I wouldn't say I abolished them completely, because I'm not sure that's possible or wise, but I could definitely quieten down what had been quite a loud inner critic, really, probably throughout my life, but certainly through my medical career. And finding that space, as you said there, about taking care of myself, was such a novel idea to me. Fundamentally, that was a new discovery that was, not just a good thing, but a really necessary thing. So in that spirit, I because I'd done a lot of education work by that stage, I thought maybe I'll go and do a master's in medical education. That felt like the obvious next step. So I started Googling around and looking at different programs, and I was reading the curricula, and nothing really got me excited, because in large part because I'd done an awful lot of it already, and it just felt like I'd just be ticking a box, and there wasn't really any joy or satisfaction that would come from that. So my eye kind of wandered across the websites, and I found something called the Medical Humanities, which I genuinely never heard of, and I know many medics who've never heard of it either. And there was, again, that very instant connection. As soon as I read the curriculum, I was like, oh yeah, that's it. That's exactly what I need to be doing right now. And so the medical humanities, for those people listening who have not heard of them, if you think of all the ologies, all the humanities, so that might be literature or history or geography or sociology or psychology, any of those, as pertain to medicine. And It's really, I think, about developing the critical thinking skills that we have in part as a medic in our kind of diagnostic processes, but this was taking it to a different level and a different approach to the developing the skill of being truly critical of an opinion. And so I signed up to do this medical humanities again, probably heroically naive, having absolutely no idea really what I was letting myself in for. And I can honestly say for the first term, I was sitting there going, "You're in the wrong place, Andy. You've got no idea what's going on, and you're never going to be able to write a dissertation." So hats off to my tutors who kept me on track and convinced me that I would get to the end, because it was such a completely different way of learning. I could feel it bending my brain. And I was very fortunate that I had one of my children at the time who was studying a humanity at university and was really helpful to me just to clarify a lot of the ideas. But I would read a page and I'd have to read it again and read it again and read it again because I literally couldn't understand the language it was written in. So it was a great discovery and thrilling, really, to find this whole world of the arts and literature opened up to me. And you mentioned about the medical identity. So again, that a little bit we're talking about having space. I was doing that course full time and still keeping one day a week in clinical practice. So I had space outside of the medical environment, but it certainly wasn't brain space because I was completely filled with these new ideas. But it gave me that breathing to be able to look at medicine from a different perspective, which was the real power of it, I think, to be able to critique it, to be able to think about why we do medicine, what's good about medicine, what's not good about medicine in very broad terms. And fundamentally, because medicine is all about humans, it's all about humanity and understanding more about humanity. So when I came to be writing my dissertation, I actually was looking at writing about drama and the use of drama in medical education. I found a whole bunch of papers on it and got very excited. And then as these things happen, serendipitously, I came across some writing by Irving Goffman, who was a sociologist in the 60s. And he was writing about the performative nature of our humanity. So we have our kind of front stage persona and our backstage persona. And he came up with this quote that I remember circling as I read it, which was, "Shame is the spoiling of identity." And this just kind of leapt out the page at me, and I was like, "Wow, but that's what is he talking about there? What is the identity, and what is the medical identity?" And I ended up furrowing off down this rabbit hole about shame and medical identity, because although I had been teaching both medical students and postgraduate doctors for years and years by that point, I'd never really come across this very concrete term of a professional identity. So unpacking that and making myself really challenge myself to understand, well, what is my professional identity? And who am I, both as a human and as a doctor? And are those two things completely merged? Or do I have a separate identity? And I think what became clear to me is that for many doctors, and I included myself in that, our professional and personal identity become completely fused. And that is fundamentally not healthy. It opens us up to the risk of shame, because shame happens when we fall short of our values. When we don't live up to that identity that have both been crafted by other people for us, but also we have expectations of ourselves. And so things that happen at work, which really should stay at work and just be part of your work bubble, if you like, come home with you and result in you attacking yourself rather than just thinking about your professional competencies. So this was all my exploration, really, that came out of that master's, which I am so hugely grateful for and was a fantastic experience. And I've carried that work forward and still teach doctors and medical students about shame and medical identity and the importance of shame in medicine. And I think fundamentally I'm much kinder to myself. I'm probably I hope, kinder to other people as a result of that experience. I think it was deeply humbling for me, and probably also very humbling to be back in that position as a student, and really a student who was flailing and struggling and grappling with difficult ideas, and remembering what that was like at a late stage in my career, I thought was very healthy and helpful for me.
I'm going to come back to the shame topic a little bit in a moment, but I wanted to ask Susy to describe this collaboration, because it does include the medical humanities. I know that in our medical humanities program here at the University of Rochester, one of the core courses that the graduate students take is called Stories in Healthcare. And so I know that you have something called, you've developed together, I believe, as I understand it, but correct me if I'm wrong, the National Health Stories experience. And Susy, if you could just walk us through, how did that come about, the genesis of it, the development, and then the experience of this story sharing medium, I guess we could call it.
Yeah, well, I got interested in stories through two podcasts. I think this is probably going back to COVID. One is the Moth and the other is the Nocturnists. And you'll know, obviously, the Nocturnists because they've done that fabulous Shame series. But the Moth, I can't remember how I came upon it, but I just really enjoyed these short form, live told stories that were non-fiction, lived experiences, true remembered by the teller, that kind of exciting what's going to happen next type story. And I remember just feeling really entertained, exhilarated, challenged, all sorts of things. And also thinking, well, wouldn't it be great to do this in the UK? These are American products and they're wonderful products. But I thought, oh, we've got some storytellers here in the NHS, surely. And so I thought about, well, I researched the way that they did it. And the interesting thing in both those outputs, the Nocturnes and the Moth, they both use story coaches. So they have a coach paired with a teller, and the two people work together on iterations of the story until the storyteller is happy with it. And so when I was pondering it, one day I was thinking, how could I get this off the ground? And I was aware that there was various small grants, or I could try and get the help of someone else. And then I thought, well, actually, I run a coaching scheme and I've got access to leadership fellows. They've all got stories to tell and I can find them a coach. So why don't we just have a go? So I did. And around about that time, I think is when I fangirled Sandy because she was on a podcast talking about shame, no less, and said at the end of it very generously, as she is a generous soul, if anyone wants to get in touch, you can contact me on whatever, this email. And I thought, well, I do want to get in touch because shame comes up all the time in my work. And I'd really love to talk about its evolution and where we can take this in medical education, because I think we need to do stuff about it. So we began communicating, and then Sandy was, fortunately for me, an eager participant in this storytelling endeavour. So we've kind of gone on this journey together. So the first National Health Stories live storytelling event was last November in Sheffield. And the next one is going to be this autumn. It's going to be in September in Sheffield again. And the format is some storytellers, but also an artist and a poet who happens to be a palliative care nurse, an extraordinary woman called Faye Marshall, whose work is excellent. And the idea is it's a celebration of humanity. So the banner across the whole event is hope and humanity. The stories in some way speak to hope and humanity. And my experience of coaching, and particularly this idea of offering people time to think, and what Nancy Klein would describe as listening to understand, rather than listening to reply. If one listens to understand, somebody can hear their own thoughts and can doubt themselves and reassure themselves and correct their own faulty thinking and come back to where is right for them. And so what I was seeing in coaching was, yes, people were expressing doubt, but they were also expressing a desire to keep going if only things could change. So I kind of felt maybe there's something we can offer people if we could offer stories of hope and humanity, which are just somebody else's tethering experiences to their anchor. Maybe that could be uplifting, it could be rewarding, it could be challenging, it could be all sorts of things. I mean, these are not easy stories to listen to. They're not kind of sugar-coated. They're expressions of life as healthcare staff. And I feel like they need to be heard. I feel like people do really tough jobs and they carry a lot with them. And it's always surprised me in healthcare that we don't give people supervision for clinical content. And I suppose this is one sort of way of offering it. It's not really supervision, but it is a way of processing and reflecting.
I also wanted to ask back a little bit about the shame. And so I'm just going to reflect on something for a bit, and you can decide whether you want to add to the national stories part or you want to answer this prompt. But you sent me a paper that you published on addressing shame, and I really enjoyed reading it. And I'll reference it in the show notes. And in it, you reinforced what I've learned in designing a course on shame that we recently designed for, that nearly 2,000 physicians actually took recently here in New York. And there were some parts about your paper that described to me what I learned, which was about the shame compass, how the behaviors evoked by this difficult but normal emotion can manifest in many ways. And it was helpful, you suggested, to become competent in recognizing it. But additionally, and I'm most curious about this, and I wonder if you could speak to this, you wrote, understanding, I'm going to read this, understanding that shame can be experienced as discomfort that highlights something of interest to the self can guide trainees to become aware of their core values and use these as opportunities for self-development. This really struck me. I'm reminded of the understanding about shame and it evoking a threat to our identity. I know you're both familiar with this book, On Apology, by Aaron Lazar. And in it, he points out one of the reasons we have such great difficulty apologizing about shame is that it's so threatening to our identity and induces that shame response. The shame that apology induces is threatening to our identity. So I'm wondering if you could speak a little bit about the awareness of our core values. How does that come out of the shame experience, and how can we access that if you'd like to go there? Or you could share a little bit more about the stories, or you could combine the two.
I'm going to add a little bit about the stories and just really to flag up how wonderfully exciting it has been. I mean, it's probably been one of the most exciting things I've been involved in. And for both our storytellers, the story coaches, and the audience who came to experience it, it's not hyperbole, I think, to say it was probably life-changing. And what I know about doctors is they're really good about telling stories about patients. And you put two doctors together, and within 5 minutes, they'll be sharing stories about patients they've encountered, but they're really not very good about talking about their own stories. And I think to provide that platform, and of course, they're extraordinary people, as you've said, Michael, and I share your thoughts on the generational differences, that it's much more perceived than actual. There are many fantastic young people, but they have been educated and brought up in a very different environment than the existing generation who are running the hospitals. So there is a lot of misunderstanding there, but fundamentally the humanity is intact, and we really need to hold on to that. And then I think about shame. I mean, at heart, at my core, I'm an educator. And so when I was exploring this idea around shame, I was thinking all sounds a little bit bleak. And I need to understand how it can be useful to us to understand about shame. And through my teaching, I realized that people would come to me after we'd spoken about shame, and there was this huge sense of relief that they were experiencing, that things that had either happened to them or that they had experienced, they could label as shame. And before that moment, they didn't have the word for it. They didn't know why it made them feel uncomfortable. They couldn't really describe the discomfort they'd experienced. And for many people, this was going back 20 or 30 years. People would talk to me about experiences that long ago. And it had just sat within them as this sort of heavy lump. And they hadn't been able to access it or identify it, and therefore hadn't been able to use it for their self-knowledge and their self-awareness. So that felt like a really nice gift to be able to give people the word, because it's not a word people are very comfortable with and will avoid using. And so just to be able to help them label what they'd experienced as shame, and to be able to say it's a completely normal human experience, right? Everybody experiences this, brought huge relief. And then I wanted to take it another step and think about, right, so what do we learn from this? And the idea that your identity is made up of your values and your experience. That's fundamentally who you are. And you experience shame when you fall short of your values. But if you were to line up a group of people and say to them, okay, what are your core values? I think a lot of people would struggle with that. So I was sort of thinking about it in the inverse, and I was thinking, right, well, if there's a room of people and something happens in that room, somebody says something or they witness something, some people in the room will experience shame and other people won't. And that's because their core values have been curtailed, have been attacked in some way. And therefore, that's your learning, because you then know, okay, this is actually really important to me. It might not be important to the people sitting around me, but that experience, that deep discomfort I'm feeling in this moment means that that is a core value for me. And I think for particularly young doctors who are forming their professional identity, to understand that would have been for me, it feels like that would have been a superpower, right? I would have known then where I needed to be, what environment I needed to be in, what type of work was most important to me, because it needed to meet those core values. And I found it, but I kind of had to wiggle my way around to get there, and I might have found a better way. But also, I think if I'd known that early in my career, it would have supported me in those times of doubt, in those times of challenge. I would have been able to hold true to recognizing that my core values are maybe very different to somebody else's. Doesn't mean I'm more or less worthy than them, but it does mean that I need to be able to meet those. And if I don't, I'm going to experience that horrible discomfort of shame. So I think as an educator, I wanted to share that learning that I'd had really through my reading, that this is where, and people are starting. Interestingly, I was reading a paper the other day where somebody's addressed exactly this, looking at how can shame be a useful teacher? How can it be utilized rather than as a weapon, but as something that actually is core to our educational experience? So it's been a great ride. I've really been fascinated by the challenge of it and seeing the light bulbs come on for people, which is always the biggest joy when you're teaching, right?
One of the threads that's running through this conversation, and even implicit in what Sandy just shared with us, has to do with connection with ourselves, how we understand ourselves, connection with others. And I know, Susy, this is a very strong interest of yours, and both of you for sure, to support health professionals' ability to connect. And I recently ran across a multicultural study that was investigating the pursuit of happiness, something we probably all care about, is important to us, which paradoxically, the pursuit itself can impair well-being. This kind of has been shown. And in this research, I was really fascinated to discover they did a multicultural study. It's about 10 years ago, and collectivistic, like more connected communities, countries, versus individualistic countries. So we could say like Eastern Asia, more collectivistic, US, just to kind of maybe stereotype a little bit, more individualistic. And in collectivistic cultures, pursuing happiness may be more successful because happiness is viewed and thus pursued in relatively socially engaged ways. So I'm wondering, Susy, maybe you could just speak a little bit about this connection piece, because I think in connection, we're social beings, whether we score on the Myers-Briggs as introverted or not. We need to connect. It's a survival aspect. So maybe talk a little bit, Susy, about how approaches and ideas you have about doing this, about helping health professionals connect.
Yes, sure. Connection. I mean, it's really how we understand ourselves through each other, isn't it? It's an essential, I do say it's an essential part of being human. And I think this is an exploration about humanity. And I suppose for me, that's where both the shame work and the storytelling work overlap. They're helping us gain depth in our understanding of what it means to be human. And I feel like a lot of the work that I do is helping people understand their normal and explore what the boundaries of that looks like, and that it is okay to feel like, for instance, I mentioned before that I run a lot of workshops on imposter syndrome. This comes up time and time again, this idea that I'm not worthy, I shouldn't be here, I fluked the system somehow, everyone else is here okay, but not me. And that's a close cousin to perfectionism. And, we select for that in medicine, don't we? So I think these are all impediments and barriers to us really showing up fully and wholly as humans in the workplace. And that's why different modes of connection, I think, are really important. I mean, I personally am someone that really struggles with social media. It just has never felt authentic to me to speak to everyone or nobody, or one person or a million people. I just can't get it's not resonant. Whereas I very much appreciate an in-depth conversation with one or two people, and this kind of experience that we're having now is joyful. So thank you for that. So I think people need different things, don't they? And I think the experience of storytelling has helped us understand another dimension of connection, that people can come along. And the wonderful thing about the storytelling is it both offers the chance to hear and listen, but it also offers the chance to be heard for the tellers. And those are other ways of connecting and hearing and holding space for people, which I think, as Sandy was saying, that they're really impactful, the stories, and the feedback we have shows us that. And people are changed as a result of hearing from someone else. But what is that? It's as a result of connecting with other people. And we're in the business of connection, aren't we? I mean, that's what healthcare is. We connect with people at their most vulnerable, and we have to have ways of coming with our full selves into that interaction. And I'm not sure that my medical training prepared me for that. I mean, I don't remember any conversation around the harder to digest or metabolize emotions like shame or disgust. I mean, often we experience that, don't we, when we see another human in suffering, or, somebody contending with a bodily function that's gone awry. It can be repulsive or disgusting to onlookers. And yet we're called to step in there, to be compassionate, to be empathetic. And that can be really difficult for people if you don't unpack it. And I think we historically have done a lot of turning away. And what we need to do is turning toward. And that turning toward is a way of deepening the connection. And I think we do know now, don't we, that better connection with patients results in better outcomes. I think that's in the evidence base. So it's sort of not rocket science, is it? But I mean, I think it took a while to get there as an actual output that we need to look for and embed. And I guess the other last thing point I'd make about connection is the connection with self has to start with self-compassion. And that's something that I see, missing in a lot of interactions that I have professionally, that healthcare professions are really good at being compassionate to other people, whilst simultaneously really poor at being compassionate to themselves. And that whole world of sitting with and allowing for, space for difficult and challenging emotional content is really important to just experience and know that that's normal and okay.
Would you like to add anything, Sandy?
I think my most powerful experience of this, I teamed up with a colleague of mine a few years ago and set up retreats for doctors. And we hummed and hawed for a long time about whether to call them retreats, because we thought no doctor is going to go on something called a retreat. And thankfully, the world has kind of changed a little bit. But putting together 6 doctors who were unknown to each other prior for a weekend of really just helping them to have a bit of space and time to think and explore and question. And the connection that happened there was honestly magical. And they probably never saw each other again, and that didn't matter. So this idea that, you have to kind of bond for life, otherwise it's worthless is really a misapprehension that people have. We can have really very brief, and obviously I have brief interactions with patients all the time, but the power of connection is there. And that is what I fundamentally love about my work, is that I'm continually connecting with people. But Susy's right in that we have no training on how to manage the emotional load that comes with that, inevitably comes with that. And we are seeing people when they are not probably at what they would call their best. I do a short course with some medical students down here in Devon on looking at emotions in medical memoirs, because there are lots of ways now in which medics record their experiences, which is fantastic. So it might be the written word, it might be in art, it might be in poetry or music, whatever. But we kind of explore those different ways. But But fundamentally, the challenge they really struggle with is, wow, am I really allowed to talk about my emotions? Is that a thing? Is that is that possible in a medical environment? And so it's still very much a taboo. And my experience is many people don't actually even have the language to be able to express their emotions, to be able to describe to me the emotional journey they might have been on through a normal day on a ward or in a hospital. They don't seem to have the words to do that. And a bit like me kind of naming shame, if you like, I feel like fundamentally we have to give these young people the permission, but also the language with which to explore their what they're feeling. And this wasn't something that was available to me, but I feel like this generation are much more emotionally literate in many ways, but not yet in the medical sphere. And I think that is ongoing work to be done.
We're winding down to toward the end of this wonderful conversation. I wish it wouldn't end. Maybe we'll have you back sometime. And I wanted to engage in a little thought experiment with you and just get your feelings about it. So imagine it's 3 years from now, or 5 years, or 10 years, or however many years it's taken for all your hard work and efforts and hopes to pay off. Health professionals in this imaginary world are feeling connected now. They're feeling competent to manage emotions such as shame. They're sharing their stories. They're caring for their patients with high quality. They're feeling satisfaction and meaning in their work. So I'm interested in each of your reflections on a couple of questions, and I'll say the questions. You can answer it any way you'd like. The first is, what would it be like for you to work in this imaginary world 3, 5, 10 years from now, as I described it? And what do you think our patients would experience in their healthcare encounters and in their health if the world was like that 3, 5 years, 10 years from now? And finally, what did you have to learn in order to get there between now and 3 or 5 or 10 or 50 years? What do we have to do to get there? So, Susy, maybe if you could start us out, just this imaginary world. I know it maybe it's the world you inhabit, and if it is, I need to spend more time with you, Susy.
Oh, I wish it was the world that I inhabit. I mean, one of my great hopes for the world is that it does adopt a stance of listening to understand, that people will, that future world will have in it people who really pay attention and don't feel the need to immediately reply. Those meetings you go to where people jump in and do what we call in coaching tailgating. The minute there's a micro sliver of time after you've said something, I'm going to jump in with my comment, and then it becomes like some Olympic battle for airtime, rather than really consciously contemplating what someone else has said and allowing it to land. And I just feel that could be a really simple intervention that, if was practiced widely, we know that listening to understand actually speeds up clinical encounters rather than slows them down. It's counterintuitive. You'd think that it would take longer if you give the patient more airtime, and we know the algorithm, we know the questions to ask. But no, of course, people are coming in their own glorious, unique selves, and we need to listen to them. And actually, that's a speedier way forward. So I do think that there's a potential there for that to make lasting difference in patient encounters, in colleague encounters, in organizations, in wider community settings or whatever. I think it's a hard ask, and I'm not sure that there's enough kind of evangelists on the ground doing the legwork. But that's, let's indulge ourselves in the fantasy. Let's imagine the world. I think that would make a massive difference. I think that this, as I've said, comes from, Nancy Klein's work around communication. And if you're familiar with it, you'll know that she has what she calls 10 components. And she says that these are all really, really important for people's quality of thinking. And if you think about where we are at the moment in the NHS here in the UK, we're at a really important juncture. We've got a brand new 10-year plan, which is the government's way of saying this is what we'd like the future to be. It talks about prevention. Now, every health plan in the past has talked about prevention, and we still haven't got there. We still haven't got a fully enabled population with agency thinking, I can take control of my health and I can make the difference. And so I really hope that this plan is the way forward and that it does it, but I'm not entirely sure that it will, but I think it would have a lot more chance of doing it if we paid attention to those 10 components. And they're all, I mean, I won't go through them all, but, if we all experienced ease, if we all offered appreciation to each other after interactions or meetings, not like blandly saying, oh, you're great. No, you're great. Not that kind of thing, but saying something sincere, succinct, and specific. We tell each other what we need to do more of. That would be an accelerator into a better, more connected, more easeful, more equal healthcare landscape. I think equality is one of the components, and my goodness, we need that, don't we, in all sorts of domains, and that would make a difference. So I feel like if I could paint a picture of the future, it would be filled with people who are really, really listening and upholding the 10 components. And we'd be walking around in a situation where really there was a lot of compassion, there was a lot of appreciation, there was a lot of care, and there was a greater sense of ease. I think one thing we have in bucket loads is a sense of urgency and kind of discontent, feeling the need to be busy, where we're not always productive in that space. And that, again, is a barrier to what we're looking forward to, and to things being, basically better for patients, better for staff.
Thank you. And interested to hear what Sandy has to add and her own thoughts on this imaginary world. But those 10 things really, I think maybe I'll try to reference that as well in the show notes. So
If I could change one thing, I've been thinking about what would I change, and it would start at medical school. It would start at the beginning, and we would change this expression of talking to patients to listening to patients. And I think that very simple switch would entirely alter the dynamic of the medical consultation. I spend a lot of my time working with younger doctors on communication skills and consultation skills, and it kind of boils down to just be quiet and stop and listen. And actually, the patient will generally give you the vast majority of what you need to know. And you may then feed in a few extra questions. And that would be the change that would bring both medics and patients huge satisfaction, because they would hear stories rather than a kind of rattling off of medical data, which is what you get if you ask people a lot of questions. And the patient will have that joy, just as our storytellers have had that joy of being truly able to tell their story. And the doctors will have had that joy of truly having heard a story. And there is something deep, deep in our DNA that is bound around stories. I think that's it. For me, if we could achieve that, it would fundamentally alter how people practice medicine, and it would fundamentally alter the patient's experience, and everything else would lead from there, I think.
as it's been said by both of you in a variety of ways, listening with the intent to understand, not necessarily with the intent to respond. And I think that alone, you're right, listening to our patients, listening to each other to understand would really go a long way. And I feel like coming into this conversation with you, and now I have a little better understanding of these concepts and also of the two of you as people. And I'm very grateful to that. So thank you very, very much.
Thank you very much.
Thanks, Meg. It's been lovely.
Thank you very much for listening. We will include a summary of the podcast and links about Susy and Sandy's work and references that were discussed in the show notes. I'd like to conclude and share another practical, brief contemplative exercise to help you flourish. Sandy and Susy shared with us about the National Health Stories experience. Although it is true sometimes we get caught in the attachment to our own stories, another truth is that we have little time or practice in reflecting upon the narratives that make up the very meaningful, rich, sometimes difficult and poignant stories in our professional lives. So let's do this. I'd like you to take a moment to just drop into the here and now, whatever that means for you, noticing your physical being, your thoughts, your emotions. And then if you could, You may take a moment, bring to mind one story from your professional life and from your point of view, the story from your point of view that occurred perhaps in the last few days, a week ago, a month ago, years ago. Just bringing that story to mind. You don't have to get all the details, but notice a little bit about the details, the context, the plot, if you will, if you could look at it that way. Characters, the thoughts, feelings, and even the body sensations that are evoked in simply reflecting on this story. And that's it. Knowing that you can engage in such reflections anytime, at the end of your workday, weekly, simply as you see fit and useful, and in doing so, noticing how it might impact the quality of your actual work, what you notice, where you direct your attention from day to day and from moment to moment. I hope you found this podcast and this simple exercise useful, and look forward to having you join us for the next episode of Flourishing in Medicine from Surviving to Thriving. To learn more about MPro, please visit www.mympro.com. To learn about their peer support programs, www.mympro.com/peer-support. And if you're in need of more urgent support, please call the Physician Support Line at 1-888-409-0141 or visit www.physiciansupportline.com. If you'd like to learn more about the work I do, please visit my website at www.mickkrasnermd.com or www.mindfulpracticeinmedicine.com. And until next time.